we have finished step 1, which was rate determination. Let's start our most important next step, that is step number 2, about rhythm analysis. In this rhythm analysis step, we are going to learn the 5 steps of rhythm analysis: sinus rhythms, general rules of arrhythmia interpretation, atrial arrhythmias, junctional arrhythmias, ventricular arrhythmias, heart blocks, miscellaneous rhythms, and in the end we will sum up all the steps in one exercise called rhythm analysis. So first question, where to check the rhythm? This is an ECG paper. Which part of the ECG paper we are going to check the rhythm? Obviously, it's on the bottom of ECG paper, which is called rhythm strip. Where else we can check the rhythm? In clinical practice, in your hospital setting, obviously your monitor defibrillator. Okay, to analyze a rhythm, we have a structured approach, and these are the 5 steps to analyze a rhythm strip. So step 1 is calculate the rate, step 2 determine the regularity, step 3 assess the P wave. Each P wave must have its own QRS complex with a ratio 1:1 ratio. In step 4, you will determine the QRS duration, and in step 5, you will assess the PR interval. Once you will apply these 5 steps, most of the rhythm strips you can easily analyze. Okay, look at the this rhythm strip, and will you calculate the rate? There are different methods we have already learned. So rate in this rhythm strip, (90 to 95 beats per minute). As this is the regular rhythm, so you can take the 300 number divided by the number of big boxes between two RR waves, like 1, 2, 3, and 3.5. So this is the approximate heart rate is 90 to 95 beats per minute. Assess the regularity. This is your step 2. So it means that look at the RR distances. You can use a caliper or a marking on a pen or a paper. Rhythm can be regular when the RR waves are equidistant. Occasionally they can be irregular, can be regularly irregular or irregularly irregular, but broadly they can be regular or irregular. So in this rhythm strip, what's your interpretation regarding the regularity? Yes, this is a regular rhythm. Now step 3, assess the P waves. First of all, ask yourself, are the P waves available? Do the P wave all look alike? Do the P wave occur at a regular rate? Is there one P wave before each QRS complex? So what do you think in this example? There is a P with QRS complex, P with QRS complex, P QRS complex throughout the rhythm strips with 1:1 ratio, and the shape of all the P waves is the same. So my interpretation is there is a normal P waves with one P wave for each QRS complex. Step 4 is the QRS duration. Look this one. The normal QRS duration is 0.04 till 0.12 seconds, or in a simple way it's 1 to 3 small boxes. So what's your interpretation here? Is the QRS complex it's a narrow or it's a wide? Means it's less than 3 small boxes or it's more than 3 small boxes. So it's 0.08 seconds, which is the normal. In step 5, determine the PR interval. PR interval from the beginning of the P wave till the beginning of the R wave. So normally this PR interval is 3 to 5 small boxes or 0.12 till 0.20 seconds. So what do you think in this rhythm strip, the PR interval? Is it normal or it's long? It's 0.12 second, which is absolutely normal. So in summary, if you want to interpret the rhythm strips, you have to go through these 5 steps. The rate, which is 90 to 95 beats per minute, it's a regular rhythm. There are P waves, normal P waves, and each P wave has its own QRS complex. QRS duration is 0.08 or narrow, and PR interval is 0.12 seconds, which is normal. So my interpretation is this is normal sinus rhythm. Now let's review the sinus rhythms. What do you mean by a sinus rhythm? Sinus rhythm means any rhythm that originates from the sinus node, SA node. SA node is the normal pacemaker of the heart, and this controls all the electrical events in the heart. So in a normal person, in a normal condition, all the times the rhythm originates from the sinus node. So if you get a P wave in your ECGs, it means it's coming from the sinus node, and you can clearly say this is a sinus rhythm. And then according to the heart rate or other findings, you can change like normal sinus rhythm or sinus tachycardia or sinus bradycardia, etc., etc. So the next question is why lead 2 is used to see the rhythm. Already we have seen in the module 1 that electricity originates from the right arm area towards the left leg direction. So if you place a positive electrode, like in case of lead 2, the vector of current will be towards the positive electrode. So the QRS complexes shall always be positive. Similarly, the P wave shall always be positive in lead 2 in most clear format. So that's why lead 2 is used to assess the rhythm most commonly. So we are going to apply the same 5 steps to analyze the sinus rhythms. These includes the rate, regularity, P waves, QRS duration, and PR interval. Let's see this first rhythm strip. Rate, is it normal, is it fast, or it's slow? So it looks like normal within 60 to 100 beats per minute. You can calculate exactly by using any formula you know. The rhythm is regular. RR interval are equidistant. There are P waves, same shape, and each P wave is followed by its QRS complex. QRS duration is narrow. And PR interval looks normal, less than 1 big box. So what's your interpretation? This is normal sinus rhythm. Now look at this rhythm. The rate, is it fast, slow, or normal? It looks like normal. Rhythm is regular or irregular. So if you see, the rhythm are slightly irregular at places, occasionally irregular. P waves, yes, there are P waves, and each P wave is followed by the chorus complex. Chorus duration is normal, and PR interval also normal, less than one big box. So here, if you see in this example, everything is normal, P wave followed by the chorus complex and T with the normal heart rate, but rhythm is slightly irregular. So this rhythm you may be seeing your clinical practice in case of children or if severe pain, and it changes with the breathing pattern, and it's called the sinus arrhythmia, although it's not a dangerous condition. Look at this rhythm strip. The rate here looks slow, fast, or normal? Yeah, obviously slow, less than 60 beats per minute. Rhythm is regular mostly. Can you see P waves? Yes. With each P wave has its own chorus complex. Chorus duration is narrow, less than 3 small boxes. And PR interval, yes, it's less than one big box, which is normal. So here everything is normal except the heart rate, which is less than 60. So this is your sinus bradycardia. So whenever you see a P wave, attach the letter, affix the letter sinus, then followed by whatever the findings you will get. Like here, only the heart rate is less than 60. This is sinus bradycardia. Here in this rhythm strip, the rate seems to be fast. It's more than 100. So this is tachycardia. Rhythm is regular. Yes. Can you see P wave? Yes, each P wave is followed by the chorus complex, same shape. Chorus duration is narrow, less than 3 small boxes. PR interval seems to be normal, less than one big box. So here in this example, the only thing which is beyond the normal range is heart rate, which is more than 100. So this will be your sinus tachycardia. Exactly. Okay. If you look at this rhythm strip, here it's slow. As far as the rate is concerned, it's occasionally irregular. You can see P wave with one chorus complex here, P wave with one chorus complex, but here no P, no chorus complex, no T. And then again it starts P chorus complex and T, P chorus complex and T. So it seems that one complete P chorus complex and T is missing. So this is called sinus block or sinoatrial block. An unhealthy SA node misses one or more cycles. Like here you see one cycle is missed. Okay, so this pause is of one cycle here. A pause in case of sinus block, there is a pause that is multiple of RR. So what it means, in case of sinus block, this missing area will be equal to either 1 RR, like this gap, or 2 RR or 3 RR. Like it's the missing area is multiple of RR. The causes includes the increased vagal tone, drugs like calcium channel blockers, beta blockers, digoxin, quinidine, and salicylates. If you see in this example, here there is a Curious complex and T, but followed by the P, and then there is a long pause of indeterminate length. So this is called sinus arrest. So sinus arrest and sinus block, if you see the difference, in case of sinus block, the pause was multiple of RR, but in case of sinus arrest, a pause is not multiple of RR, but it's indeterminate length. It's a more serious condition, and causes may include the sinus node ischemia, hypoxia, digitalis toxicity, increased vagal tone. There is another rhythm which may originate from the sinus node. It's called sick sinus syndrome. This happens due to the dysfunction of the SA node, which causes failure to generate impulse. This may be associated with bradyarrhythmias, maybe tachyarrhythmias, most commonly with bradyarrhythmias. The causes includes the fibrosis of SA node, myocardial ischemia, digoxin, cardiac surgery, old age. One of the variety of the sick sinus syndrome is tachybrady syndrome, where there is a burst of atrial tachycardia, for example, atrial fibrillation. Then this is followed by a long symptomatic sinus pause or arrest with no breakthrough junctional rhythm. So there is a tachycardia burst followed by the sinus pause, and then again the sinus node takes over. So this is sick sinus syndrome, and a variety of sick sinus syndrome here is in this example is tachybrady syndrome. So the clinical pearls in this sinus rhythms that you have to keep in mind, that any rhythm where you detect a normal shaped P wave is a sinus rhythm. Very important. Whenever you detect a normal shaped P wave, it's a sinus rhythm. And any rhythm with no or abnormal shaped P wave is not a sinus rhythm. That may be coming from ectopic focus, or maybe this is a SCAP phenomena, and we are going to talk this in detail in coming slides. So far we have talked about the steps of rhythm analysis and some sinus rhythms. Now we'll talk about the most important subject, arrhythmias. Before talking about each strip, it's important to go through the general rules of arrhythmia interpretation. Okay, so let's review once again the normal conduction system and the complexes, ECG complexes produced by the flow of electricity in the heart. When the electricity originates from the SA node, okay, it travels across both the atria and reaches to the P wave, and reaches to the AV node, and we get the P wave. Then the electricity stays here for some time, we get the PR interval. Then the current flows very fast to both the ventricles, and we get the big Curious complex. And when the ventricles relax, we get the T wave. So P, Curious complex, and T. So these are the normal deflection on the ECG paper when the electricity goes through the cardiac conduction system, and heart has to go through these complexes 60 to 100 times per minute in adults. Now few rules of rhythmia interpretation. The rule number 1, sinus node is the normal pacemaker, as we have discussed previously, but impulse can be generated anywhere in the heart. So what it means? Any area any wall, any muscle, any chamber of the heart is capable of generating its own electricity. But the nature has protected from this one, because the God has gifted us with the SA node, which normally files and controls all the electrical events. But in between, sometimes there are irritable areas because of hypoxia, some other conditions that may be capable of generating electricity. That areas are called potential pacemakers or ectopic foci. They can be in the atria, they can be in the AV junction, they can be in the ventricles or anywhere in the heart. They can be single, they can be multiple. So then they accordingly they produce the different type of arrhythmias. Another mechanism is, if the normally, as I said, the SA node works and it's responsible for generating electricity. But if SA node is dead, is no more working, is sick, heart is not going to die, then AV node will take over. If the AV node is also not working, heart is not going to die. There should be some area to generate the electricity, and the Purkinje system can also generate the electricity if both the SA node and AV node are not working. So this is called escape phenomena. These are the backup system. So these are the two main reasons of arrhythmia generation. And obviously the third reason is the reentrant phenomena, where the electricity may enter from atria to the ventricles and produce the arrhythmias, or it may moves in a circular fashion to generate the arrhythmias. And this is what we are going to talk now. In rule number 2, re-entrant phenomena or circus movements are mainly responsible for tachyarrhythmias. What it means? In case of normal flow of the electricity, it goes very nicely from SA node to the AV node and to the Purkinje system. But if the source of electricity is outside the normal conduction system, the electricity may flow in the atria in a circular fashion, or it may flow, if it starts from the ventricles, it may move in the ventricle in a circular fashion, or it may enter from the atria to the ventricle and goes back, which is called re-entrant phenomena. So these are the important mechanism of generation of electricity and the generation of the arrhythmias. The rule number 3, a rhythm at or above the AV junction is a narrow complex, and below the AV junction is wide complex. So narrow means less than 3 small boxes or less than 0.12 second, and wide means more than 3 small boxes or more than 0.12 second. So any rhythm which originates above the AV junctions, like for example the atria or AV node, are narrow complexes, and from the ventricles they are wide complexes. So we'll apply these 5 steps of arrhythmia interpretation and the general rules of arrhythmia interpretation in the coming slides. So let's start with the first, with the top story, that are the atria. Look at the rhythm strip here very carefully. The rate seems to be normal. Rhythm here is occasionally irregular. You see the distance here, RR distance, and here the RR distance are variable. So this rhythm is irregular. Can you see P waves in this complex number 1? Yes, P wave with chorus complex. But the complex number 2, if you see, the shape of the P wave is different. Then followed by the chorus complex. Then again complex number 3, normal shape P and chorus complex. 4th, 5th, 6th, and 7th, it's again abnormal shape P waves. Okay, chorus duration. QRS duration throughout the rhythm strips is normal, narrow complex, and PR interval, wherever normal shape P waves, the PR interval is normal. But where the abnormal shape P wave, it's difficult to determine. But it looks normal. So what's this rhythm? Obviously, these are the normal shape P waves, so your diagnosis will be the normal sinus rhythm. But what about these two complexes? So these are coming a little bit early, prematurely. So these are the sinus rhythm with premature atrial contractions. So from where they are coming? So this complex, first one, is coming from the SA node. If you see P wave with chorus complex and T. So SA node, as I mentioned earlier, is a father in the family. So it controls the electrical events. But in between, this complex number 2 is fired by this naughty child, this ectopic focus. But the father is strong enough, the SA node is strong enough, it takes over, and then it keep on sending its own current. In between this complex number 7, again this ectopic focus fires. So these complex number 2 and 7 are coming from this ectopic focus. The rest of the complexes are from the sinus node. And if you see, all are narrow complexes, and by rule any rhythm which originates above the AV junction is a narrow complex. So these are most probably from the atria. So that's why they are called the premature atrial complexes. Look at this one. The rate here looks a bit slow. Rhythm is irregular. You see the variability between the RR waves. Now, important look at the P waves. Yes, P wave with chorus complex and T looks like normal. But here, if you see the second wave, the P wave is inverted. And if you see the third wave, there is P wave, but it's a different shape. So in fact, we are getting 3 different shape of P waves. This may be normal, and the rest of the 2 may be abnormal. And the ventricular rate is less than 100. QRS complexes are narrow. So it means coming from above the ventricular area. And PR interval, wherever available, it looks normal. So what's your interpretation? Heart rate less than 100 and 3 or more different shapes of the P waves. It's called wandering atrial pacemaker. So what it happens, the pacemaker wanders, moves from one place to other, like here in this example you can see. Look at this one. Here rate obviously more than 100, so this is tachycardia. Rhythm looks irregular. You see the RR distance is variable. Look at the P wave. P wave is there, but the next P wave is different shape. This is different. So 1, 2, 3, 3 different shapes of the P waves are seen. Okay, with heart rate more than 100. QRS complexes are narrow, so it means they are coming from above the ventricles, like from the atria, and PR interval is different because the P wave shapes are different. So again, here there are 3 different types of the P wave. The source definitely moves from one place to the other place. They are narrow complexes. So this is called multifocal atrial tachycardia. The P wave are seen, but they are abnormal shape P wave. Maybe one of them is normal, but there are different shapes of the P waves. So in case of wandering atrial pacemaker and multifocal atrial tachycardia, the difference is heart rate. If it's less than 100, it's wandering atrial pacemaker. If it's more than 100, it's multifocal atrial tachycardia with 3 or more different shapes of the P waves. The impulse originates from the varying points in the atria in case of MAT and wandering atrial pacemaker, and there is variation in the P shape, PR interval and PP interval, and therefore in RR intervals as well. Let's practice 1 or 2 steps. What's the rhythm here? You just reflect yourself and apply the 5 steps. The rate is fast, the rhythm is irregular. See the RR distance. P wave of different shapes, more than 3 shapes. Chorus complexes are narrow and PR interval is variable. So this is your multifocal atrial tachycardia. Look at the bottom. Rate looks like normal, less than 100. It's irregular. P wave are seen, but different shape of P waves. PR interval, the chorus duration is narrow and PR interval is variable. So here 3 are different shapes of P waves, but heart rate less than 100 and narrow complexes. So this is wandering atrial pacemaker. Look at this rhythm strip. Rate here, ventricular rate. Here which method you are going to apply, because this is irregular, so you cannot apply the big box method or sequence method. Here 6-second strip. So like this, for example, this hole is the 30 big boxes, 6-second strip. So 1 2 3 4 5 6 7 8 9, so 90 or 80 approximate heart rate, ventricular rate. Rhythm is completely irregular and bizarre. You can't see any P wave. These are the notches only. These notches sometimes seen, sometimes are not seen. When seen, they may be called fibrillatory waves. Chorus duration is narrow throughout, so it means the source is from the atria. And PR interval, of course, no P wave, so no PR interval. So this is your atrial fibrillation, because this is completely irregular with no P waves. So here in atrial fibrillation, the sinus node goes into the sleeping mode and it's completely taken over by the ectopic foci, multiple ectopic foci in the atria. So they are like children who are jumping in the bed. Some are capable of reaching to the AV node, then AV node sends the current nicely to the ventricles and we get the chorus complexes. Some are just keep on moving within the atria and not able to reach to the ventricles. Some are reaching to the ventricles, and then we are getting the chorus complexes. Look at this rhythm strip. The ventricular rate looks like fast, more than 100. It's irregular. It's hard to find the P waves, and chorus complexes are narrow. So this is atrial fibrillation, but as the heart rate is more than 100, so it's called atrial fibrillation with fast ventricular rate. Look at this one in the bottom. It's slow. heart rate less than 60, you can apply the 6-second method. It's irregular. P waves are not seen, and the Kurtz complexes are narrow, maybe slightly wide. So this is again atrial fibrillation with slow ventricular rate. Look at this rhythm strip. The heart rate here seems to be normal, less than 100. It's irregular. It's hard to find any P wave, and the Kurtz complexes are narrow. So this is again your atrial fibrillation, but here the ventricular rate is normal. So you can label it atrial fibrillation with normal ventricular rate. Look at this important rhythm strip. Here, if you see the rate, ventricular rate, we are talking about the ventricular rate. It's less than 100. It's like, for example, here it's it's regular, so we can apply 6-second method or large box method. Okay, let's apply the large box method. 1, 2, 3, 4, 4.25. So or roughly 4. So 300 by 4 is 75, 80. So here ventricular rate is approximately 75 or 70. Approximate. Exact heart rate you will see only on the ECG paper. Rhythm is regular. Now it's important here, P waves. We are getting these notches. These are not P waves because the P wave is usually slightly rounded and it must be followed by Kurtz complex with 1:1 ratio. If it's a P wave, then each P wave must have its own Kurtz complexes, but it's not. So these are some special waves. So these are 1, 2, 3, 4 waves. So these are called flutter wave. Okay, and the shape is sawtooth shape. Kurtz complexes are narrow, so it means they are coming from the atria above the ventricles, and PR interval, because no P waves, no PR interval is seen. So this is your atrial flutter with 4:1 conduction. So what it means, in case of atrial flutter, there is only one ectopic focus, unlike atrial fibrillation where you will get multiple ectopic foci. But in atrial flutter, only one ectopic focus, but it moves in the atria 1 time or 2 time or 3 time or 4 time or 5 time. So more it moves in the atria, more flutter waves you will get. Here I want to bring another very important information in your knowledge, that each area of the heart is capable of generating electricity. We have mentioned also. So like SA node fires at 60 to 100 beats per minute, AV node 40 to 60, Purkinje system 20 to 40. But other areas like myocardium in the atria or in the ventricles also producing electricity, but relatively very, very high rate. So atria can generate electricity at 250 to 350, even more beats per minute. But God has protected this fast, this abnormality by giving us giving us the SA node. We are blessed to have the SA node that controls such abnormal activities. In the case of atrial flutter, there is one ectopic focus. So as I said, it's moving in the atria. Like if the rate is 300 and if the electricity from the atria to the ventricle reaches at a rate of 300 and our heart rate is 300, we are not going to survive. So that's usually doesn't happen. So most common form of atrial fibrillation is 2-into-1 conduction. That is 2 times the impulse moves in the atria, then goes to the ventricles, and we get heart rate of 150. If it moves 1, 2, 3 times, we'll get the 3 flutter waves and heart rate of 100. If it moves 1, 2, 3, 4 times and then goes to the ventricle, we'll get the 4 flutter waves and heart rate about 70 to 75. Like in this example, 4 flutter waves and ventricular rate is around 75. If it moves 5 times, we'll get the 5 flutter waves and heart rate of 60, and so on. So this is your atrial flutter. Look at this on the top, this rhythm strip. Here heart rate is exactly close to 150. 2 big boxes, 300 divided by 2 is 300. And here our differential diagnosis is sinus tachycardia versus atrial flutter with 2-into-1 conduction. So in your clinical practice, sometimes a patient comes with the heart rate close to 150 and you are not sure whether this is sinus tachycardia or it's atrial flutter with 2-into-1 conduction. And you know, if there are few clinical features which can differentiate atrial flutter from sinus tachycardia, like atrial flutter happens all of a sudden, but sinus tachycardia, there must be some reason like blood loss or fluid loss, but sometimes it's not clear. So in this example, if there is no contraindication, you just apply the carotid sinus massage. So what carotid sinus massage will do, it will delay the flow of electricity through the conduction system from the atria to the ventricle, from the SA node to the AV node. And what will happen, once the electricity is blocked at the AV node, the flutter wave will become more and more prominent and more in number. So this will give a clear picture that whether it's a sinus tachycardia or atrial flutter with 2-into-1 conduction. Look at this example at the bottom of this strip. This is your rhythm strip here, and heart rate is close to 150. So in your emergency department or in your ward, if you get a heart rate of 150, close to 150, one of your differential diagnosis must always includes atrial flutter with 2-into-1 conduction. Like here, if you see, it's a fast 150 heart rate, it's irregular. It's very hard to see any P wave. Some notches are seen, like this sort of notches. These are actually 2 flutter waves, and it's a narrow complex. So this is narrow complex tachycardia, and most probably this is a atrial flutter with 2-into-1 conduction, because it's regular. So that's why we say it's a fixed 2-into-1 conduction. But look here, this example, this is a fast, obviously this is a tachycardia, but here it's irregular. P waves are difficult to find, but some notches are there, which confuses us whether this is something from the atria waves, like, and sometimes we are confused whether the no P waves are seen, and it's a narrow complex. So again, these notches are more in favor of atrial flutter, but here with variable conduction. So when the conduction becomes variable, so this is called atrial flutter with variable conduction, and when it becomes variable, then the differential diagnosis with atrial fibrillation becomes a challenge. So question is, how will you differentiate atrial flutter with a variable block from atrial fibrillation? So answer is very difficult. Very difficult on ECG, and you can take it as atrial fibrillation if you are not sure. So how can we overcome this problem? So this is another special lead which is called Lewis lead or S5 lead. It's a modified lead to detect the atrial flutter. So Lewis lead or S5 is a modified lead to detect the atrial flutter. So here a right arm electrode is placed on the patient's manubrium sterni. Left arm electrode is placed on the fifth intercostal space on the right side, and left leg electrode is placed on the right lower costal margin. So here in this, the lead 1 is taken as monitor lead, and if there is any atrial flutter, it will becomes very prominent because the electricity will be perpendicular to the vector of the current, and this flutter waves will be very easily seen. Normally we don't do this one in practice, but just for academic point of view, it's very important. So let's review few rhythms again. So on the top, what's the rhythm here? So ventricular rate seems to be normal. It's regular. Regular means coming from one focus, one source. No P waves. These are the notches, just these are narrow complexes, and no PR interval. So this is your sawtooth pattern. So this is obviously atrial flutter. But look at the bottom, it's tachycardia, no P waves, it's irregular, narrow complexes. So this is your atrial fibrillation. Now let's go through another very important rhythm strip. And most of people who are working in the critical areas, emergency department or cardiology units, they come across this type of rhythm. Here the rate is fast. Obviously this is tachycardia, and it's regular. It means coming from one source. No P wave. Chorus complexes are narrow. So narrow means coming from the atria, and no PR interval. So this is your supraventricular tachycardia or SVT. Here the source is 1. So it produces electricity and goes to the AV node and to the ventricle, and here a little bit electricity is checked. So ventricular, that's why it's difficult to cross more than 200 in adults. So there is another variety of the SVT is called paroxysmal supraventricular tachycardia. What it means, PSVT is a term used to describe SVT that starts and ends suddenly, or there is features of the normal sinus rhythm. Look at here, P wave chorus complex T, P chorus complex T, P chorus complex T. Then this is some abnormal activity, some ectopic focus takes over from the SA node, and it starts generating its own electricity in form of SVT. So here in SVT, the mechanism is reentrant phenomena. The impulse originates from the from the ectopic focus in the atria, and then it makes a reentrant loop around the AV node and then goes back to the atria, and these loops keep on moving and produces continuous narrow complex SVT. Look at the bottom of this. This is tachycardia, regular, no P waves, narrow complexes, no PR interval. So this is against your supraventricular tachycardia. Sometimes we apply the carotid sinus massage to treat the SVT before so medicine reaches. If you have time, so you can apply if there is no contraindication. So what it does, carotid sinus massage, the stimulation, it causes stimulation of the carotid sinus, which triggers baroreceptor reflexes and increases the vagal tone. This vagal tone affects the SA node and AV nodes, so the conduction in the system gets slow. So SVT may be reverted because it will give enough time to SA node to recover and takes over. There are some medicine which can also block this conduction through the AV node, so like adenosine. So here if you see, this first part is SVT, very fast narrow complex tachycardia without P wave. Then this is followed by the sinus arrest, and then this normal sinus node restores. So for SVT, there is intervention here. Adenosine is given, which causes the sinus arrest, and then the SA node takes over and produces its normal complexes. Now we have finished the atrial tachycardia. Now it's time to go through the junctional arrhythmias. So two mechanisms here. First mechanism is junctional escape rhythms or junctional escape mechanism. As I mentioned, SA node is the normal pacemaker of the heart, but if the SA node dies, heart is not going to die. Heart will continue its activity and AV node will take over. And the question is, what will be the ventricular rate here? 40 to 60, exactly. So look at this rhythm strip. So let's apply the 5 steps of arrhythmia interpretation. The rate is here is between 40 to 60. You can count. Rhythm is regular, so it means coming from one source, no P waves. So what it means? It means it's not coming from the sinus node. QRS duration is narrow. That means it's above the ventricles, and PR interval may or may not be seen. But here in this example, no P waves, so no PR interval. So what's this rhythm? Yes, junctional escape rhythm. Look at this. Here if you see, the heart rate is more than 60, but it's less than 100. Rhythm is regular, so it means coming from one source. P wave not seen at all. QRS duration is narrow, so it means above the ventricles, and PR interval nothing. So again, this is junctional escape rhythm, but as the heart rate is more than 60, so we'll call it accelerated junctional rhythm. So let's identify few rhythms. If you see here, slow heart rate is less than 60, no P wave, narrow complexes. So this is your junctional rhythm or junctional escape rhythm. Here if you see, slow heart rate between, not slow, heart rate is between 60 to 100, less than 100 I mean, but more than 60. There are some abnormal inverted P waves. So obviously these are not the sinus. So these are abnormal narrow complexes. So this is your accelerated junctional rhythm, and in the final rhythm strip on the bottom, this is tachycardia more than 100. No P waves. These are abnormal inverted P waves, which are definitely abnormal, and they're not coming from the sinus node. They're coming from the junction, somewhere from the junction. So this is your junctional tachycardia. So the difference between these three rhythms is the heart rate. If heart rate is 40 to 60, it's junctional rhythm. If it's between 60 to 100, it's accelerated junctional rhythm. And if it's more than 100, it's junctional tachycardia. So one mechanism of junctional arrhythmias was escape phenomena, okay, where the SA node doesn't fire and AV node takes place. The second mechanism where the electricity can be produced from the junction is potential pacemaker or anectopic foci. Anectopic foci can be seen in the atria. We get the premature atrial complexes. But if the ectopic focus is over the AV junction, this area, it can produce premature junctional complexes. And obviously the pacemaker ectopic focus can also be seen in the ventricles, and we'll talk later. But here we'll focus on this point, premature junctional complex produced by this ectopic focus or the ectopic foci that are available, that can be found on the junction. Look at this rhythm strip. If you see here, the rate is obviously slow, and it looks like mostly regular P waves. There are no P waves seen, but abnormal shape of P waves is seen. That's inverted P wave here before the Kurus complex, or no P wave at all, or maybe P wave after the Kurus complex. So if you see an inverted P wave before or after the Kurus complexes, or not at all, just keep in mind that these abnormal inverted P waves are absent P wave. The source is AV junction, and it depends upon the level of the ectopic focus. So it's common, or it may be seen in case of junctional rhythms, that ventricles and atria, they contract together. When they contract together, you don't see any P wave. But if the atria contract before the ventricles, you will get the inverted P wave before the Kurus complex. And if the atria contract after the Kurus complex, you will see the inverted P wave after the Kurus complex. And also the level of the ectopic focus. If it's the high part of the AV junction, you will get the inverted P wave before the Kurus complex. If it's in the lower part of the AV junction, you will get the inverted P wave after the Kurus complex. And if it's the right in the middle of the AV node, you will not get the P wave at all, because here the atria and ventricles, they contract simultaneously. Look at this example. Rate is here slow, rhythm is irregular. Look at, can you see P wave? Here, yes, P wave followed by the Kurus complex. But here, no P wave. In the second complex, no P wave, but Kurus complexes are there. Again, P wave, Kurus complexes, and finally P Kurus complexes. So it means complex number 2 is different than the rest of the three complexes. Gauss duration is narrow, so it means all are coming from above the ventricles. And PR interval, it's increased in long in complex number 1, 3 and 4, and we'll talk later about this, the importance of PR interval in blocks. But here just focus this. The first, third and fourth complexes are coming from the sinus node, but the second one, it's coming from the AV junction, from the AV node. So there is ectopic focus which tries to take over from the sinus node. This nutty child fires its current in complex number 2, but SA node, the father is strong, so it keeps on controlling the electrical events within the heart. But in between this ectopic focus, this nutty child fires itself. So to differentiate the premature junctional complex from junctional rhythm is that in junctional rhythm you will see absent of P waves throughout the rhythm strip, but in case of premature junctional complex you will see some few complexes here and there in the ECG. Like here in this example, this is a sinus rhythm with premature junctional complex. Look at this. This is ECG strip. The rate is fast and rhythm is regular. So one source. P waves are not seen, but if you see, there may be some notches after the QRS complexes. QRS durations are narrow, so it means it's above the ventricles, and PR interval obviously not seen. So this is your junctional tachycardia. Clinically, it's very hard to differentiate junctional tachycardia from the supraventricular tachycardia. In fact, junctional tachycardia is also a supraventricular tachycardia, but for academic sake, we are just trying to differentiate it from the SVT, classical SVT. So we have finished atrial arrhythmias, junctional arrhythmias. Now let's come to the basement of the house, the lower floor of the house, which is the ventricles, and we'll talk about the ventricular arrhythmias. Let's see the two examples of normal and abnormal flow of electricity within the heart. Normally, the signals originates from the SA node and moves very rapidly to the AV node and to the ventricles. So this is the normal conduction system. But in case of ventricular arrhythmias, the impulse may originate from the myocardial muscle and keeps in a circular fashion within the ventricles. So as it's not following the normal conduction pathway, so the flow of the electricity within the myocardium from one ventricle to the other ventricle is relatively slow. So remember, when an impulse originates in a ventricle, conduction through the ventricles will be inefficient and the QRS complexes will be wide and bizarre. So again, two mechanisms of arrhythmia production. In case of ventricular arrhythmias, one is the escape mechanism, others will be the ectopic foci. So let's talk first about the ventricular escape rhythms. So if SA node fails to fire, heart is not going to die. AV node takes over. If the AV node also sick, is unable to generate electricity, heart will never die. The Purkinje system will take over. Okay, and the ventricular rate will be very slow. So look at this example. Here the rate is 20 to 40 beats per minute. Rhythm is regular. So one source. P wave not seen. So it's not from the from the atria. QRS complexes are wide. Look at the base. QRS complexes are wide and PR interval not applicable. So wide QRS complexes means coming from the ventricle. So this rhythm strip, if you see, is a slow and regular, no P waves and wide QRS complexes. So this is your ventricular escape rhythm. It's also called idioventricular rhythm. Look at this rhythm strip. The first part is the sinus rhythm. Let's focus the second part. Rate here is more than 40 but less than 100, and it's irregular. It means one source. We can't see the P waves here, and QRS complexes are wide, no PR interval. So here we have wide QRS complexes. The rate is more than 40 but less than 100. So this is ventricular escape rhythm, but the rate is more than 40. So when the rate is more than 40, we label it accelerated idioventricular rhythm. Right? The difference between idioventricular rhythm and accelerated idioventricular rhythm is the rate. Less than 40 is idioventricular rhythm or ventricular escape rhythm. More than 40 but less than 100 is accelerated idioventricular rhythm, and above 100 is ventricular tachycardia. Here question is, how will you differentiate accelerated junctional escape from accelerated idioventricular rhythm? Answer is obviously the width of the QRS complexes. They are wide in case of accelerated idioventricular rhythm, but they are narrow in case of accelerated junctional escape rhythm. Look at the bottom of this ECG rhythm strip. The rate is less than 100 but more than 40. It's regular, no P wave. QRS complexes are wide. So again, this is your accelerated idioventricular rhythm. The second mechanism which can be seen in case of ventricular arrhythmia is the potential pacemaker that can be found within the ventricle. So like if one ectopic focus is present in the ventricle, it may produce the premature ventricular complex. So as I said, whenever an ectopic focus is present in the ventricle, some area of irritability due to the hypoxia or decreased blood supply, it may cause irritation of the ventricular muscles and produces a premature ventricular complex. So this ectopic focus or nutty child in the ventricle is responsible for this premature ventricular complex, which is very bizarre and wide. Let's review this rhythm strip. The rate here looks normal. Rhythm is irregular in between. P waves in the initial 4 complexes are normal with normal QRS complexes, but in 5th cycle and 7th cycle they are different complexes, no P wave and very bizarre and wide QRS complexes. So these are your premature ventricular complexes, and PR interval obviously in the first 4 complexes is normal and 6 also normal, but 5th and 7th is not available. So this is your sinus rhythm. The first 4 complexes sinus rhythm with premature ventricular contractions or complexes 5 and 7th complex. Again, the first 4, the source is SA node. But 5th and 7th, the source is in the ventricle, ectopic focus from two different sources, because there are two different shapes of the Curious complexes. Now, if you look at these three complexes, we are going to learn the terminology for these PVCs. Look here, the shape of PVCs here, two PVCs. These are normal, three complexes, then PVC. The shape of these PVCs is the same. If you get the same shape of PVCs, it's called uniform or unifocal PVCs. If you get two different shapes, two or more different shapes of the PVCs, it's called multiform PVCs. If you get two PVCs together, it's called paired PVCs. If you get three or more PVCs together, this may be ventricular tachycardia. Sometimes you see a PVC alternating with normal Curious complex. Means one normal Curious complex, one PVC. One normal Curious complex, one PVC, and so on. This is your ventricular bigeminy. You may also come across two normal shape Curious complexes, one PVCs. Two normal, one PVCs. This is called ventricular trigeminy. Or three normal Curious complexes, one PVCs. You may label it ventricular quadrigeminy. Another important findings we have to keep in mind when you are dealing with the PVCs, that's the R on T phenomena. What it means, the R of the PVC, this R wave of PVC falls on the T wave of the normal Curious complexes. And we all know that the T wave is produced by the ventricular relaxation, ventricular repolarization. So in this repolarization phase, the heart is in relaxing mode. Okay, but if during this relaxation mode some electricity starts in, so this may produce the fatal consequences. So it's very important to keep an eye on the R on T phenomena, because this abnormal ectopic focus, if it stimulates the normal myocardium when it's in the relaxation phase, it may produce the ventricular fibrillation. So important to look into R and T phenomena. Okay, let's review this rhythm strip. Here the rate is fast, very fast, and it's regular. It means one source. P wave not seen, so it's not from the sinus node. Curious complexes are wide. So wide, it means it's from the ventricle, somewhere from the ventricle. And PR interval, obviously none. So this is your monomorphic ventricular tachycardia, because the shapes are same. And it's regular because source is one. And it's wide, so from the ventricles. So identify this rhythm. So easy. These both are monomorphic ventricular tachycardia. Again, look at this one. If you look carefully, this is your monomorphic ventricular tachycardia, obviously. But if you see, it's persistent, it's sustained, it's continuous. It's called sustained ventricular tachycardia. But you look at the bottom of this bottom strip, you will see the three Curious complexes, then in between again one normal beat, then again three. As I mentioned earlier, three or more PVCs together is ventricular tachycardia. So again, this is a ventricular tachycardia, but this is non-sustained. All right, coming back. Okay, moving forward to the next strip. Here the rate is fast, and rhythm is irregular. P waves are not seen. But if you see the chorus complexes, they are different shapes, like you see here, different shape of the chorus complexes. Again, this is a different shape of the chorus complexes. So what it means, it's coming from maybe this area, the complexes are coming from one source, this is from other source, this is from the third source. So from different sources they are coming, and PR interval is obviously not seen. So these are the wide complexes. It's a tachycardia. Okay, it's a wide complex tachycardia. Okay, but it's polymorphic. So it's polymorphic ventricular tachycardia. The source is from multiple areas. So here there are multiple ectopic foci. They have taken over the complete control of the electricity and responsible for creating this type of arrhythmia. Look at this rhythm strip. Rate is fast, so obviously tachycardia, and it's irregular. It's irregular. P wave no seen, and chorus complexes are wide. Okay, and PR interval obviously not seen. So again, it's a polymorphic ventricular tachycardia. But here, if you just focus this ECG strip, you will see this group of chorus complexes same. Then the other group of chorus complexes are same. It looks that this all from one source, this all from another source. Then again, these complexes looks like identical from one source. So this is a special variety of polymorphic ventricular tachycardia called Tarsard de Ponis. Tarsard de Ponis means twisting of the points. Here, the important thing is there is one ectopic focus, but it's twisting around its points. So sometimes it's producing chorus complexes, a bunch of complexes of the same shape, then bunch of complexes of other shape, then again bunch of complexes of different shapes, because it's twisting from one point to another point, although the source is one. Look at this one. This is more clear. There is a bunch of complexes of different shapes, which gives it to the polymorphic ventricular tachycardia shape. But in fact, this is Tarsard de Ponis. It's very important to try to differentiate Tarsard de Ponis from the normal polymorphic ventricular tachycardia. For this one, you have to try to find the patient's previous record. If on ECG, you find that the patient has long QT interval in the previous ECGs, so this polymorphic ventricular tachycardia you are encountering with previous history of long QT interval is Tarsard de Ponis. Sometimes the patients have bracelets or anklets or necklace that I am the known case of Tarsard de Ponis. So then you will be careful, especially in the emergency department, where such patient, if comes in a stable clinical conditions, we have the protocols to start the amiodarone. But if you start the amiodarone for the Tarsard de Ponis, it prolongs the QT interval, and already Tarsard de Ponis is precipitated by the long QT interval. Giving amiodarone is further harms the patient. So you have to be careful and give the magnesium sulfate. So it's very important to differentiate polymorphic ventricular tachycardia from Tarsard de Ponis. So the message is that with any polymorphic ventricular tachycardia with a long QT interval is Tarsard de Ponis, and with a normal QT interval with the polymorphic ventricular tachycardia. Look at this rhythm strip. Here on the paper, if you see, you maybe find a very fast heart rate, but if you attach this patient to the monitor will be unable to record the ventricular rate. The reason is that it varies very fast from 60 to 200, 100 to 250, 300 to 75. So it's so variable heart rates that even the monitor is unable to determine what's the heart rate. So rhythm is completely bizarre, completely irregular. No P waves, and QRS complexes are wide. So it means it's coming from multiple sources within the ventricles. There are so many ectopic foci, so many nutty childrens that they have suppressed the SA node completely. Even if in between SA node is firing, it's very hard to detect its activity. So this is your ventricular fibrillation. So ventricular fibrillation can be coarse or can be fine, and it depends the size of the QRS complexes. If they are more than 3 mm, this is coarse ventricular fibrillation. If it's less than 3 mm, it's a fine ventricular fibrillation. If you get a fine ventricular fibrillation on ECG, you just increase the size of the QRS complexes, and if it's ventricular fibrillation, it will become obvious. If it's not, then you may label it as asystole. Look at this ECG rhythm strip. No rate, no regularity, no P wave, no QRS complexes, no T wave. So everything is gone. So this is your asystole. These are few agonal beats, which is a part of the asystole. So in summary, tachyarrhythmias are fast, rate is more than 150 beats per minute, and look at the P wave. If you see a normal shape P wave, it's sinus rhythm. If you don't see P waves, so it's definitely the source is ectopic somewhere else. There may be narrow complexes or wide complexes tachyarrhythmias. Narrow complexes are atrial in origin, wide complexes are ventricular in origin most of the time. They can be regular like SVT, VT, or maybe irregular like atrial fibrillation, ventricular fibrillation, polymorphic ventricular tachycardia, torsades de pointes. So, all right, we have finished so far the tachyarrhythmias. This is the time to review the heart blocks. But before going through the heart blocks, let's review the cardiac conduction system once more. This is some graphic presentation of the cardiac conduction system. You see the impulse originate from the SA node, then through the internodal fibers, it goes to the AV node. Here the electricity stays for some time, 1/10 of the second, and then it goes to the bundle of His, and then a right bundle branch and left bundle branch. The right bundle branch continues as Purkinje fibers, but the left bundle branch divides into the left anterior fascicle and left posterior fascicle, and then this fascicle further divides into the Purkinje fibers. So electricity can be blocked at the SA node, and we get the sinus arrest or sinus block. Electricity can also be blocked or delayed at the AV node, and we get first degree, second degree, and third degree AV blocks. If the electricity blocks at left bundle branch or right bundle branch, we get the left and right bundle branch blocks respectively. Electricity can also be blocked at the left posterior fascicle. We get the left posterior fascicular block or posterior hemi block. And electricity can also be blocked at the left anterior fascicle, and we get the left anterior fascicular block or anterior hemi block. So electricity can be delayed or blocked anywhere in the conduction system, and we get different types of the conduction delays or blocks and these are seen on ECG. Look at this rhythm strip. The rate seems to be okay, normal. Rhythm is irregular here. We can see P wave. Yes, P wave occurs complex T, P wave occurs complex T. But here complete cycle is missed. No P, no occurs complex, no T. And then again the normal P occurs complex T starts. QRS duration is narrow and PR interval seems to be okay. So the only finding here is one cycle is completely missed. So this is your sinoatrial exit block or sinus block. Now let's talk about the AV blocks, which are very important clinical findings. For the AV blocks, it is extremely significant and important to check the PR interval. What's PR interval? The PR interval presents the atrial depolarization plus the delay of the electricity at the AV junction. So this delay allows time for the atria to contract before the ventricles. So PR interval starts from the beginning of the P wave till the beginning of the R wave. So normal PR interval is 3 to 5 small boxes that are 0.12 till 0.20 second. If it's prolonged, we get different shapes of the or different AV blocks. Okay, let's apply the 5 steps of rhythm analysis again on this rhythm strip. The rate here looks like slow. Rhythm is regular. P waves are seen, and each P wave has its own QRS complex. Now QRS duration is normal, it's narrow. But if you look at the PR interval, this is prolonged. This is more than one big box. So this is your first degree AV block. So let's try to make it more simple. My duty starts at 7 o'clock, but I am a little bit lazy and I reach my hospital daily at 8 a.m. So routinely I should reach 7, but I'm coming to the hospital daily at 8 a.m. Why? Because I have first degree AV block. So daily, Monday, Tuesday, Wednesday, Thursday, Friday, whenever I come to the hospital, I'm regular, but I'm coming to hospital daily 1 hour late. Okay, look at this rhythm strip. The rate is slow. Rhythm is irregular. Can you see P wave? Here is important. Okay, P wave, P wave, P wave, P wave. Now look the relationship between the P and QRS complex. This P has QRS complex. This P, no. This P, yes. This P, yes. This P again, yes. This P, no. This P, yes. So it means some P waves are conducted, some are not conducted. Now look at the QRS duration. It's narrow, but PR interval. Let's focus this one, PR interval. Here, if you look at the PR interval, here is slightly increased. Here PR interval is more increased, here more increased, and here this P wave is not followed by the QRS complex. So it seems there is a gradual lengthening of the PR interval till the P wave is not followed by the QRS complex, and then this cycle repeats itself. This gradual lengthening of the PR interval and then some P is not followed by the QRS complex and the cycle repeats itself is called Winky-Bach phenomena, and this type of block is called second degree type 1 AV block or Mobius type 1. So again, it's Monday, my duty starts at 7. Okay, I'm at 7 in the hospital. But Tuesday, I'm a little late. I'm 8. At 8 a.m. I came to the hospital. Wednesday, I came at 9 a.m. and Thursday, I'm absent. So gradually, daily, I'm taking advantage and I'm getting late. And one day, nobody's asking me, so I escape from my duty. So this type of block where there is a gradual lengthening of the PR interval till the P wave is not followed by the Icarus complex and the cycle repeats itself is called second degree AV block type 1 or Mobius type 1. So see the Winky-Buck phenomena again. So there are gradual lengthening of the PR interval till this P wave is not followed by the Icarus complex and then the cycle repeats itself. Now look at this rhythm strip. The rate is slow and rhythm is irregular. You can see P wave. But some P wave has Icarus complexes, some P waves they don't have. Means some are conducted, some are not conducted. Icarus duration here is slightly wide. But look at the PR interval. Wherever PR interval is available, here, it's constant and it's fixed. It's not gradually lengthening. Whatever it's there, it's same. So this type of block is called second degree AV block type 2 or Mobius type 2. In Mobius type 2, some P waves are conducted, some are not conducted, but those who are conducted, their PR interval remains the fixed and constant. So again, my example, it's Monday, I come to hospital at 7 a.m. Tuesday, again, I'll come to 7. But Wednesday, Thursday, I missed. So because I was very regular, so my hospital authorities, they were expecting me to come on Wednesday again, but I missed. So this sudden drop of the Icarus complex is dangerous, like in this example. So this can lead to the complete heart block. So in second degree AV block, Mobius type 2, there are normal Icarus complexes, but all of a sudden some P waves are not conducted to the ventricles. Look here, the rate is slow and it's regular. The P waves, some P waves are conducted to the ventricles, some are not. One is conducted, one is not. One is conducted, other is not. One is conducted, other is not. So this is second degree AV block, but it's 2 into 1 AV block. Okay, one is conducted, other is not conducted. So two P waves and one Icarus complex. That's called 2 into 1 AV block. Look here. Here some P's are conducted, some are not conducted. Okay. So this is again second degree AV block type 2 with variable AV block. So look again at the PR interval, it's constant. Okay, so let's go through another rhythm strip. Here the rate is slow, even it's less than 40. Rhythm is regular. P wave, there are more P waves than the Icarus complexes. So it means maybe these extra P waves are not conducted. Icarus duration is wide. So wide means it's coming from the ventricles, and PR interval none, or maybe variable if you see. But if you see clearly here, the PR interval, it has no relationship. The P wave has no relationship with the Icarus complex. The PR interval is very variable. Okay, so if you see the distance between the two P waves, like here, the P wave is here, one P wave is here. So they are equidistant and regular. So what it tells us that these P waves are coming from the sinus node, okay, because they are the same shape. Now look at the RR waves. They are also equidistant, but a rate of 40 beats per minute, and they are wide, and wide comes from the ventricles. So it means they are coming from the ventricles. The P waves are coming from the atria, but they are not going from the atria to the ventricle, because there may be some blockage at the AV junction. But the ventricles are not going to die. They are generating their own current and from the Purkinje system. So that's why the ventricle rate is slow, 20 to 40 beats per minute. So this is a complete blockage of the electricity. It's called complete heart block or third degree AV block. In third degree AV block, atria and ventricles beat independently. There is complete atrioventricular dissociation. No more relationship between the atria and ventricles. So atria and ventricles act independently. There is no flow of electricity from the atria to the ventricles. And it's a dangerous condition. Look at this one. This P followed by the Kurus complex. This P, no, this P very long distance. So it looks like the PR intervals are variable and complexes are wide. So this looks like the atria and ventricles are beating independently. So this is third degree AV block. But look here, again here, there is no relationship between the atria and ventricles as PR intervals are variable. Sometimes even P waves are after the Kurus complexes. There is no relationship. So again, this is a complete heart block. But the question is here, as we mentioned, if there is a complete heart block and if these Kurus complexes are coming from the ventricles, they must be wide, like in this example. But why they are narrow in this example? So if I say that there is a complete blockage of the electricity, then from where these complexes are coming? So the answer is, this depends upon the level of blockage. If the blockage is high up at the AV junction, you will get the narrow Kurus complexes and complete heart block. But if the blockage is quite low in the AV junction at the level of the bundle branches, top of the bundle branches, you will get the wide Kurus complexes. So we can differentiate two varieties of the third degree AV block, that is the nodal complete heart block, and this is the infranodal complete heart block. So in summary, there are three types of the AV blocks. First degree AV block, where the only finding is the prolonged PR interval. Second degree AV block, which has further two types, type 1 and type 2. In type 1, there is gradual lengthening of the PR interval, then one of the P wave is not followed by the Kurus complex, and then the cycle repeats itself. In second degree, some P waves are conducted to the ventricles and sometimes some are not conducted to the ventricles. But PR interval, wherever available, is fixed and constant. And in third degree, P waves, they are produced on their own pattern and Kurus complexes on their own pattern. That is complete atrioventricular dissociation. Let's practice few bradyarrhythmias. Just focus the rhythm strip. It's slow. It's irregular. P waves are seen some places. You see this P Kurus complex this P Kuras complex, this P Kuras complex, this P Kuras complex, but this P, it's hard to find Kuras complex, these two. Then again this P Kuras complex, this P Kuras complex, and then again starts. It's narrow complexes, then PR interval. It's here normal. It's prolonged, more prolonged than this P. Then this P is not followed by the Kuras complex. So this is your Vinci-Bach phenomena. This type of block is called second degree AV block or type 1. Look at this one. So it's slow, regular. Some P waves have Kuras complexes, other they don't have. This P wave, this one doesn't have Kuras complexes. Narrow complexes, Kuras complexes, and the PR interval wherever available, it's constant and fixed. So this is your second degree block, type 2 with 2:1 conduction. Look at this one. This is slow heart rate and it's regular. P waves are seen independent of the Kuras complexes, and there is variable PR interval. It looks that atria, they have their own rate and ventricles have their own rate. So this is complete heart block nodal type because Kuras complexes are narrow. So again, look at this one. So is this one first degree, second degree, or third degree AV block? So take your time and try to interpret. So use 5 steps: rate, regularity, P wave, Kuras duration, and PR interval. So important thing is keep in mind the PR interval. So PR interval wherever available are fixed and constant. Some P waves are conducted, some are not. This P wave is conducted, this P wave is not, and PR interval is constant. So this is your 2:1 AV block or second degree type 2 AV block. Look at this one. Apply the 5 steps again. So this is your second degree type 1 AV block or Vinci-Bach phenomena. You see the gradual lengthening of the PR interval till the P wave is not followed by the Kuras complex. Finally, look at the final rhythm strip on the bottom. Apply the 5 steps and here comes your answer. So there is no relationship between the P and Kuras complexes. P waves atria are contracting by their own and ventricles are contracting by their own. There is variable PR intervals. If you look RR distance, it's equidistant. If you look at the PP distance, it's the same. One piece buried here. So this is your complete heart block or third degree AV block. Look at this one again. Try to solve it. So your answer is second degree AV block type 2 because some P waves are not conducted, some are conducted. This is again conducted. This is not conducted. This is conducted. So wherever PR interval, it's the same and constant. So this is your second degree AV block type 2. Look at this one. Try to find out the most important thing in diagnosing AV blocks is the PR interval. So look here. PR interval is gradually increasing till the P wave is not followed by the Kuras complex, and then the cycle repeats itself. It's a Vinci-Bach phenomena, and this block is second degree AV block type 1. And look at the bottom. This is regular
and all the P's are conducted, and PR interval remains the same, but it's prolonged more than one big box. So this is obviously your first degree AV block. So far we have dealt with most of the rhythmias. Now few miscellaneous rhythms you should also get familiar with this. So look at this one, this rhythm strip. You can't apply any of the 5 steps because no rate, no rhythm, no P waves, no chorus complexes, no PR interval. So this is your asystole. And the bottom, there is again asystole. Some notches are seen in terminal patients. So again, this is P wave asystole. This rhythm you can also see during when you failed your CPR resuscitation efforts. So only these notches are seen like P waves, but no ventricular activity. So this is again your asystole. This is called P wave asystole. You may come across this type of rhythm. You see here the normal chorus complex, and all of a sudden the ventricular stop beating, although the atrial activity is there. So this is again asystole. This is ventricular asystole. Sometimes you will see such type of rhythm strip. Yeah, although it's hard to find, hard to apply these 5 steps of rhythm interpretation because these are very naughty, very strange type of complexes and which are not seen in the normal ECGs. So this is your artifacts. These are loose electrodes or muscle tremors. So you should be familiar with this one. These are also artifacts. Sometimes the cable artifacts or paper get jammed and you will get such complexes. So don't interpret it wrongly. So these are all your artifacts. So if you get such type of funny ECG deflections, so your differential diagnosis may include the muscle tremors, respiratory artifacts, loose electrodes, broken lead wires, etc. Okay, this is another rare rhythm strip. Let's apply the 5 steps. The rate here, the rate is here. If you see, in some places it's fast, and other places it looks normal. So you can apply the 6-second method. Rhythm is irregular. You can obviously see P waves. Let's focus the P waves. This P wave, yes, with the chorus complex. This, yes, with chorus complex. This one also with chorus complex. This one, in fact, all the P waves are followed by the chorus complex. Okay, but if you just focus the shapes of the P waves, there are 2 shapes like this one and this one. You can see the difference of the P waves. This one and this one, this one and this one. Like, just focus this shape, type of small P wave, then this is a normal P wave. This P wave, one of them is the normal, and one is probably this is normal, this is coming from somewhere else, normal somewhere else. So these are 2 different shapes of the P waves, and chorus complexes are narrow, so it means they're coming from the atria. So the diagnosis in this one, these are 2 different shapes of the P waves. This is sinus rhythm with atrial bigeminy. If it's 3 or more, then this will be wandering pacemaker. If the heart rate is less than 100, or junctional tachycardia if the heart rate is more than 100. But here, if you see, there are 2 shapes. So this is your atrial bigeminy. how to differentiate with the atrial bigeminy with the sinus arrhythmia. In sinus arrhythmia, all these P waves will be the same shape, but in atrial bigeminy, two different shapes of the P waves. So this is your sinus rhythm with atrial bigeminy. Okay, another new rhythm. This one, look at this rhythm. If you see, there are certain extra waves, extra notches before the P waves. The P, Kuros complex, and T, but this one additional lines. These spikes, additional spikes, are from pacemaker. As they are before the atria, it's atrial pacing. Here, if you see, these additional spikes are before the ventricles. So these are your, this is your ventricular pacing. In this rhythm strips, these spikes are before the atria and before the ventricles. So these are dual chamber pacemaker. Here, if you see, these are the spikes from the pacemaker. So pacemaker spikes should produce the Kuros complex. So we should expect that this pacemaker must produce the Kuros complexes, but here it's not producing. So this is failure to output. The pacemaker does not generate a pacemaker spike when it's needed. So here, if you see, these extra spikes, pacemaker spikes, are there in the first four complexes, and the rest ECG, they are not there. So whenever it's needed, the pacemakers are producing the Kuros complexes. When it's not needed, they don't produce. So this is demand pacing. Pacemaker generates impulses on demand. If you see, the normal Kuros complexes are coming, and in between the pacemaker generates its own spike. Okay, somewhere pacemaker is producing its own spikes. So pacemaker does not recognize the normal beats and generates an unnecessary pacemaker spike. This is failure to sense. All right, so far we have gone through all the components in this rhythm analysis. That includes the 5 steps of rhythm analysis, sinus rhythms, general rules of arrhythmia interpretation, atrial arrhythmias, junctional arrhythmias, ventricular arrhythmias, heart blocks, and miscellaneous rhythm. This is the time to go through an exercise about the rhythm analysis. Are you ready? Let's begin with the rhythm number 1. And just go through all the steps and you have to answer me. So you have learned all these steps, just apply these steps and then you will get the answers. So rate here, 30 beats per minute. Regularity, it's regular. Can you see P waves? Yes, they are normal. Kuros duration, it's narrow, 0.10 seconds. PR interval, it's normal, 0.12 seconds. What's your interpretation? It's sinus bradycardia. Rhythm number 2, look at this rhythm strip and what's the rate? It's fast, 130 beats per minute approximately. Regularity, regular or irregular? Regular. Can you see P waves and its relationship with the Kuros complex? Normal P wave with 1:1 ratio. Kuros duration, narrow or wide? Narrow, 0.08 second. PR interval, normal or prolonged? It's normal, 0.16 second. So your interpretation, this is sinus tachycardia. So whenever you see a P wave, you have to affix the term sinus and then according to the heart rate, sinus tachycardia. Look at this rhythm number 3. Rate here, the slow, fast, normal. What's the rate? Apply whatever method you know. 70 beats per minute approximately. It's a regular or irregular, occasionally regular, marked at the red arrows. Here it's, you see, irregular. P waves, just look at the shape of all the P waves and its relationship with the Curis complexes. 2 P waves out of 7 are different contour. P wave at complex number 2 and 7 are different shape. QRS duration, narrow or wide? Narrow. So means coming from the above the ventricles. PR interval, so it's normal except the area which is pointed by the red arrow. So what's your interpretation? This is normal sinus rhythm with premature atrial complexes. Rhythm number 4, rate, slow, fast, normal. It's 60 beats per minute. Regular or irregular? Occasionally irregular. Can you see P waves? Scan the whole rhythm strip till the end. P waves is seen throughout except the 7th QRS complex. QRS duration, it's normal throughout except the 7th, which is wide QRS complex. PR interval, normal throughout except the last one. In your interpretation, sinus rhythm with 1 PVC. So this PVC, as this complex is wide, it's coming from the ventricle. So this is premature ventricular complex. The rest of all the complexes are coming from the atria, from the SA node, but this one is coming from the ectopic focus, which is present in the ventricle. Look at the rhythm strip number 5. Rate and regularity. As this is irregular, so you will apply the 6-second method, and the rate is approximate 100 beats per minute. Is it regular or irregular? It's completely irregular. Very bizarre. Irregularly irregular. P waves are seen or not? Not at all. QRS duration, narrow or wide? It's narrow. It means it's coming above the ventricles, somewhere from the atria. PR interval, none. So your interpretation, atrial fibrillation. Rhythm number 6. Look at this rhythm strip. And rate. Rate means ventricular rate. Slow, fast, normal. It's approximately 70 beats per minute. Is it regular or irregular? Regular. Can you see P waves? No. These are abnormal shape notches are called flutter waves. Sawtooth pattern is seen. QRS duration, narrow, 0.06 seconds. And PR interval, none, because no P waves. So your interpretation is atrial flutter with 4:1 conduction. So rate here. So just for sake of interpretation, just divide this rhythm strip in two parts. The first part, read it separately, and the second part, read it independently. Okay, so first half the rate is different and the second half rate is different. So like first half it's approximately 75 beats per minute, and second half it's close to 150 beats per minute. Regularity, first half is regular, second half is also regular. P waves, in first half P waves are seen, but in second half not seen. QRS duration is narrow in both first and second part of this rhythm strip, that is 0.08 second. So it means source for both rhythms are above the AV junction. So source here, this first half is sinus node because there are P waves, but the second half is something coming from ectopic focus. PR interval in first half you get, but in the second half there is no PR interval. So your interpretation is a paroxysmal supraventricular tachycardia. So SVT alternating with the normal sinus rhythm. Okay, so rhythm number 8. Rate is fast. Here this is tachycardia, 160 beats per minute. It's regular. P waves are not seen. QRS duration is very wide. PR interval none. And your interpretation, the same shape of QRS complexes. This is monomorphic ventricular tachycardia. Rhythm number 9. Rate, if you see here, looks fast, but in the real life it's very, the monitor, it's unable to read. So that's why we say it's none, but you can calculate this is very, very fast at this moment of time. Regularity, completely irregular. No P waves and very wide and bizarre QRS complexes. PR interval none. So your interpretation is ventricular fibrillation. Look at this one, the rate here. It's very important before calculating the rate, just give a look on the regularity. So this looks like regular and it's 60 beats per minute. P waves, yes, seen throughout, and each P wave is followed by the QRS complex. QRS duration is narrow, so it means coming from the atria or at the AV junction, and it's 0.08 seconds. No, important point is here is the PR interval. Just focus the PR interval. It's long. It's 0.36 seconds. So only abnormality here in this ECG rhythm strip is the prolonged PR interval, and this is hallmark of first degree AV block. Look at this rhythm strip, the rhythm number 11. First step, rate. Rate is slow here and it's irregular. So that's why you should apply here 6-second method or 3-second method. P wave are seen, and it's this normal shape P waves. But if you see the relationship between the P wave and QRS complexes, some P waves are not followed by the QRS complexes. This fourth P wave doesn't have QRS complex. QRS duration is narrow, but important, look at the PR interval. PR interval is getting gradually lengthened till the P wave is not followed by the QRS complex, and the cycle is going to repeat itself. So this is called Vinky-Bach phenomena. And what's your interpretation? Second degree block, type 1. Okay, look at this rhythm strip, which is the rhythm number 12, and here the rate is slow, 40 beats per minute, and it's regular. P waves are seen, but all the P waves are not conducted to the ventricles. Some are conducted, some are not conducted. QRS duration is narrow, but just focus the PR interval. Wherever it's available, it's fixed and constant. So this P wave is conducted, these two P's are not conducted. Again, this P wave is conducted, these two are not conducted. This P wave is conducted, these two are not conducted. And look at the PR interval, wherever available, it's constant and fixed. That is 0.14 seconds. So what's your interpretation? This is second degree AV block type 2 or Mobis type 2. Look at this one, the rate is slow, 40 beats per minute, and it's regular. Can you see P wave? Obviously P waves are seen, and it has no relationship with the QRS complexes. QRS duration is wide. And PR interval, if you look, it's variable. Actually, it's hard to detect the PR interval. So your interpretation, it's third degree AV block. Atria and ventricle are acting independently. There is complete atrioventricular dissociation, no relationship. If you see the RR distance, they are equally apart. If you look at the P waves, they are equidistant. So atria are beating on their own, ventricles are beating on their own. All right. So we have finished the step 2, which was about the rhythm analysis. Now we are moving towards the step number 3, which is the axis determination.